Hi, good afternoon, everybody. Thanks so much for joining us today in the webinar. We're going to be talking about identifying and reducing disparities in care for racial and ethnic minorities. And the webinar today is actually part of a larger series that we're doing at the Robert Wood Johnson Foundation, focused on collecting and sharing strategies from hospitals, clinics, and others. And these strategies focus on how to improve equity in healthcare. This series details lessons that we've been learning from the Foundation's Aligning Forces for Quality initiative, and our hope through these webinars and through many other efforts is that these lessons can be adapted and applied by others, many of you on the phone, working in this area to improve healthcare quality and equality. So, as I said, I'm Susan Mendy, and I am a Senior Program Officer here at the Robert Wood Johnson Foundation, and I'm going to be the moderator today. We're going to be joined by representatives from two Aligning Forces for Quality alliances, Thomas Love with the Better Health Greater Cleveland Data Center, and Cheryl Gibson Fountain, who comes to us from Greater Detroit Area Health Council. After the presentations, we have set aside plenty of time focused on questions and answers, so please do hold your questions until then. However, throughout the webinar, we really encourage you to tweet about what we're talking about and your thoughts about it, and join the conversation online. So you can follow this conversation by using the hashtag #AF for Q. Again, that is #AF, the number 4, and Q. You know, as many of you probably know, disparities is an issue that we have been grappling with in America for many years, and we have worked long and hard to address this issue. We've been trying to address it in healthcare, but also in many other areas of our lives and culture. And earlier this month, we as a country marked the 50th anniversary of the signing of the landmark Civil Rights Act. And this very critical act outlawed discrimination based on race, color, religion, sex, or national origin. Unfortunately, although we have made tremendous progress since then, we in the healthcare community still face the unquestionable truth that disparities in healthcare are alive and well. Indeed, 38 years after the signing of the Civil Rights Act in 2002, the Institute of Medicine released its seminal report entitled Unequal Treatment. For the first time ever, this report showed significant variations in the quality of care that racial and ethnic minorities receive in the United States, and these disparities persist even when insurance status, income, age, and severity of condition were comparable. And these disparities are displayed as existing in the slide above you even today. In its most recent update to its annual National Healthcare Disparities Report, the U.S. Agency for Healthcare Research and Quality showed that disparities in the quality of care that patients receive remains a common thread. For example, it showed that blacks receive worse care than whites, Hispanics receive worse care than non-Hispanic whites for about 40% of the quality measures that they reviewed. American Indians and Alaska Natives received worse care than whites for 1/3 of the quality measures, and Asians received worse care than whites for about 1/4 of the quality measures reviewed. But Asians did receive better care than whites for a similar proportion of quality measures. You know, as many times as I look at these numbers, and you probably join me in this, I'm really shocked at them. Unequal treatment is certainly not something that we seek to deliver, and many of us actually don't think that we deliver it. We're not really aware that we're delivering it, but however, the impact on our patients is very, very real. And as America's minority populations continue to grow and are estimated to be a majority of the population by the year 2043, addressing these inequalities becomes even more urgent. Um, so that sounds pretty depressing, but I think that we can all really take hope because many people who are joining us today, and certainly our presenters on the phone, have really sought and found some wonderful approaches to addressing disparity in healthcare. And we at the Robert Wood Johnson Foundation have really put reducing inequities at the core of our grant making for quite a long time. So as I mentioned to you when we first started the webinar, one such initiative that we're going to be talking about that the Foundation has undertaken and is still involved in is called Aligning Forces for Quality. 7 years ago, the Foundation launched Aligning Forces for Quality, which is our signature effort to improve healthcare quality at the local level, focusing in 16 communities across the entire United States. This Aligning Forces for Quality effort brings everyone together in the healthcare community, including the people who get care, the people who give care, and the people who pay for care. So over the years, this initiative has undertaken several quality improvement efforts. It's certainly worked to address racial and ethnic disparities in care. It's worked to institute systems to measure physician performance. It's introduced strategies to reduce unnecessary use of the emergency department, as well as many other quality improvement initiatives that are happening in these 16 communities. And so together, these communities have really learned a lot about what works and what doesn't work in this area. The Aligning Forces for Quality program is going to come to a close next year, but our critical step now is to share those hard-won successes and lessons that we've learned with the rest of the healthcare community, and that is why we are here with you today. So we did quite a thorough analysis at trying to identify some key elements that makes work in these areas successful. And three of the ones that have really stood out are in the slide in front of you. Number one, reporting leads the way. You know, it's the old adage, you can't manage what you don't measure. And so in order to reduce disparities, organizations and regions need to really first understand where these disparities exist, how big the problem is, and really dig deep to try to figure out the root causes. Second key observation is that it takes a multi-stakeholder village. We all know that disparities are the result of some really complex interactions. And in these Aligning Forces for Quality communities, multi-stakeholder coalitions that include community consumers, providers, and payers are all working together, and it's really vital that they work together if these communities are really going to reduce health and healthcare disparities. And having these types of collaboratives on board and in place helps to move from taking this data that the communities have been gathering around disparities to actual action to address these disparities. Third key point is you need to have patients at the table. The cultural background of each one of us certainly influences our experience of care as well as our health behavior. And so bringing patients and communities to the table at the very beginning to help design programs to reduce disparities allows them to voice their concerns, identify challenges, and give some real-world input into design and implementation. Over the past several years, these Robert Wood Johnson Foundation initiatives have developed some innovative strategies for identifying and addressing disparities, and we're going to be hearing about two of these initiatives today. First, Better Health Greater Cleveland will discuss their experience in implementing and aligning systems in Cleveland to collect data to measure equity and disparities. And secondly, we're going to be hearing from Detroit, the Greater Detroit Area Health Council, who will discuss their learnings from a peer-to-peer storytelling project that was focused on reducing disparities in care. So I'd like to now turn the webinar over to Thomas Love, and he is the Director of Better Health Greater Cleveland's Data Center. And Tom has worked to align the various electronic health record systems in the Cleveland area with the idea of aligning them so that they can collect and report patient race, ethnicity, and language data. He's going to talk to us today about their data collection process and how they've been using this process to understand and to act on the disparities that they identify in the region. So, Tom, welcome to the webinar, and thanks so much for joining us today.
Thank you, Susan, and thank you, everyone, for tuning in. I am, Susan's got it right, I'm the director of the data center at Better Health Greater Cleveland, and I'm going to talk a bit about how our work on reporting care and outcomes of patients with chronic illness like diabetes and high blood pressure has motivated the decisions that we've made about how to think about disparities in the region. When we started this work, we were thinking about disparities in two ways. One way is through race, ethnicity, and language issues that have been raised. And another is with other potential disparities across the region that might partially account for some of these differences that we might see by race. And so in that area, I'm referring to things like what type of insurance someone has, or whether they're treated at a system that has an electronic health record or not. And so one of our early interests was in trying to communicate to people how the sites, the practice sites, the health systems, and the region in general, how the patients that were going to those places were distributed, not just by race and ethnicity, but by other issues as well. And so one of the key applications of the work we've been doing in disparities is keeping up that communication. Of course, we look and have looked over time at building systems which allow us to identify and describe regional disparities in achievement across numerous categories of disparities, and to look at these things over time as well. And then we decided that there was a need for both public reporting on these issues, which we do primarily at the regional level, and also reporting that we do to try to identify particular trends and opportunities for identifying best practices across the region. And so I'll return to that. But that material is mostly contained at a members-only site available to the people who are participating directly in what we're doing. So let me be specific about what we're looking at. We've been collecting data since 2007, since the beginning of the Aligning Forces Project, on a number of issues related to disparities. So certainly we've been collecting information about race and ethnicity and what language someone prefers to speak, but other issues as well. We've been using data from the census and now from the American Community Survey to estimate median income levels for our patients, depending on what part of the region they live in. So these are data describing the individual practices for one of our reports, and you can see that at one practice, the average income of patients was about $28,000, and at another it was $79,000, and that's an enormous gap. And you can see we sort of populate the entire range between $28,000 and $79,000. So what that says is, if we don't make some effort to understand differences in a broader way than just race and ethnicity and language alone, we're not going to understand those racial disparities as well as we might. So income is one area that we've looked at. And we've actually looked at numerous other issues as well. So on the next slide, which should come up in a moment, there we go. On the next slide, I list on the left some of the things that we look at to try to understand the people who we're reporting on. So one of the things we look at, of course, is whether or not they have any of several conditions that we report on. So we report on patients with diabetes and patients with high blood pressure, and many people have both of those conditions, for instance. But then moving down the list, we report on whether patients receive care from electronic health record systems or systems that are using paper records. And this was a major area of disparity at the beginning of our work. Back in 2007, this was, in fact, the major difference that we could identify between systems. And so now, thanks to a number of changes, all of our systems now report with electronic health records. But when we began, that was a very big area of disparities. A second area is insurance, and again, recent changes, particularly in the state of Ohio, have changed the mix of insurance quite a bit, but we still see large differences, as I'll show you in a moment, by insurance type. Then next on our list was race, ethnicity, and language preference. So our systems, our data systems, provide data on all of these issues when they're submitting data about patients. So we get data on what type of insurance someone has and what their self-reported race and ethnicity information are, and all of these other issues. And the reason we do that is we try to gather the data in as granular a way as possible so that we're capable of developing reports that look at trends over time about things that we weren't necessarily thinking about at the beginning of our work. So when we started doing this, we were focused essentially just on insurance and race in terms of reporting things out. But over time, we've started to look at a lot of other issues. I should just go through the list. In addition to race, ethnicity, and preferred language, we look at gender. We look, as I mentioned, at some Census American Community Survey-related data regarding income and educational attainment based on where you live. And we also look at the place of residence in broad terms, people who live within the city of Cleveland, within its surrounding counties, suburbs, and then within counties outside of our main area. So the idea here was to try to figure out multiple ways in which the patients might be different, and multiple ways in which we could investigate potential disparities and ideally find potential solutions that might be especially appropriate within a particular racial or ethnic group once we had accounted for some of these other issues. So what we do with our regional reporting is try to highlight things that show larger differences. So if you look at this particular slide, this is a slide that describes our two main diabetes measures. The one on the left is an outcomes measure, and the one on the right is a care measure. So the outcomes measure on the left is what I'll focus on for now. And the idea there is that what goes into someone's diabetes outcomes, how well they're in control of their diabetes essentially, are multiple issues. And we wanted to try to account for some of those differences in behavior, in genetics, in what happened to them in the doctor's office. We wanted to try to account for, to some extent, what was happening to them outside of the doctor's office by understanding more about what was going on. So the four bars highlighted in blue are actually the insurance bars. You can see the Medicare group at the top is doing very well. Larger numbers are better here. Then the commercial group is sort of in the middle, near the average, and uninsured and Medicaid are much lower than the rest. So the disparities by insurance are quite large. But if you look at the remaining ones, for instance, comparing whites to African American or Hispanic patients, you can see that while there are substantial differences by race, they are relatively small compared to the differences we see by insurance. So we've made an effort in thinking about racial differences to think about other issues at the same time. What is the difference between patients who are white and African American? Well, one of the differences we see in Cleveland is that they live in different places, that they're more likely to have different types of insurance, and so any solutions that we come up with need to be attentive to other gaps that we see in our disparities data. Finally, just to conclude, on the members-only side, we also look at these issues, and there the race data are highlighted in blue. We also look at these issues down to the level of individual physicians to try to get an understanding of whether there are big differences between the groups that we've defined in multiple ways. So this is an old slide, but is looking at a grid that we make available to all of our participating members. And it's looking at the region, at how their particular system and practice are doing, and then how the individual, in this case they're all physicians, they could be nurse providers as well, how the individual providers are doing on our main measures, but also how they break down by these various demographic considerations, including insurance on the right and race, ethnicity in the middle. Over time, we've learned that the main idea here is to get the corresponding systems to provide as much data about disparities as possible, And then we need to feed that back to them by systems like this members-only thing so that they can get an understanding of why this might be valuable to them in thinking about what's going on. Well, I think I've used my time, so I guess I'll pass it along at this point to Cheryl. Thank you.
Thank you so much for that, Tom. I think you've really hit home the point about how much coordination has to happen between the data sets in order for us to get a really accurate picture of disparities. And until we have that picture, we certainly cannot act in a meaningful way. So that was wonderful. Thank you so much for sharing that. So now I would like to introduce Dr. Cheryl Gibson Fountain, who comes to us from the Greater Detroit Area Health Council. Dr. Fountain is a member of the Greater Detroit Area Health Council's board, but she's also a member of their Race, Ethnicity, and Language Committee. The Detroit Alliance has been coordinating a number of really great projects in this area around addressing disparities. Some of their projects include a multi-stakeholder Race, Ethnicity, and Language Committee that I've just described to you, Dr. Fountain sits on, videos to increase understanding of race, ethnicity, and language data collection and why this is happening, and more. And we're going to be hearing some of that more today. So Dr. Gibson Fountain, welcome, and thank you for joining us today.
Thank you, Susan. I'm really excited to be participating in this webinar today and would like to take this opportunity to first thank the Robert Wood Johnson Foundation's Aligning Forces for Quality initiative and the Greater Detroit Area Health Council under the leadership of Tawana Nettles Robinson for helping us to reduce the disparities in our out-of-control hypertension rates and improve disease management skills in our African American patients here in the Metro Detroit area through our Greater Detroit Area Health Council Hypertension Intervention Project. We know that high blood pressure is the #1 modifiable risk factor for heart disease and stroke. The higher one's blood pressure, the greater the risk of heart attack, congestive heart failure, stroke, and kidney disease. So as you see here, metropolitan Detroit ranks second in the nation in hypertension hotspots, with Michigan ranking among the top 10 states in the country for cardiovascular death. Heart disease and stroke are the first and third leading causes of death here in Michigan and across the nation. African Americans have the highest prevalence of high blood pressure, 37%, that's 2 out of 5 people compared with other races. And African American females actually have a higher prevalence of high blood pressure, 44.3% compared to African American males at 40.5%. African Americans here in Michigan make up 14% of the general population, yet they make up 47% of the population receiving dialysis, partly due to their higher prevalence of high blood pressure and diabetes. The Greater Detroit Area Health Council has developed a health improvement initiative focused on reducing disparities in hypertension rates that can lead to cardiovascular mortalities and morbidities in our African American populations. Our initiative combines 2 culturally appropriate interventions. First, the development and distribution of interactive patient-centered peer-to-peer storytelling digital video disc DVD recordings. These DVDs highlight the patient's own stories to promote adherence to hypertension medication regimens and detailed tools to achieve blood pressure controls for African American patients. And second, the implementation and utilization of a health literacy screening tool into current electronic medical record systems or other systems that enhance physician and patient communication and evaluates patients' understanding of medication and recommended healthcare regimens. Both of these interventions focus on improving quality of care for targeted patients, reducing disparities in out-of-control hypertension rates, and improving disease management skills here in our African American patients. Our initiative actually combines 2 culturally appropriate interventions detailed by Finding Answers, Disparities Research for a Change, which is a national Robert Wood Johnson Foundation program focused on discovering and evaluating innovative interventions to reduce racial and ethnic disparities in health care. Our first initiative uses peer-based storytelling to help patients improve their blood pressure and self-management skills. And the second utilizes a provider-evaluated clinical screening tool to assess the patient's health literacy and improve provider-patient interaction, communication, and the patient's health literacy. Utilizing the very successful culturally sensitive intervention from Birmingham, Alabama, utilizing this model, which was done as a part of the Finding Answers with the Robert Wood Johnson Foundation Finding Answers grant, we have actually developed our own GDAC hypertension intervention project. The patients in our project receive a 3-disc DVD digital recording to promote adherence to hypertension medication and to achieve blood pressure control for them. The DVDs utilize stories drawn from our community, and they are told in the natural voices of the patients to inform and inspire positive health behavioral change. For many minority populations, peer-to-peer learning can be invaluable among patients that have reason to distrust the medical establishment and may prefer to actually take their health behavior cues from friends and families. Pictured in this slide, you see the back cover of our 3-disc hypertension intervention project video with photos of our powerful storytelling participants. Just going across the top, you'll see Gail, patient Herman, Dr. Myers, our patient Jacqueline. Going on to the second row is Michael, Dr. Clark, a father and son, Enoch the third and the fourth, and Thomas. In the third row, pictured Dr. Elrod, James and Pam, husband and wife, Dara, and Keith and Leela, another husband and wife team. On the last row, you see Cynthia, Dr. Levy, myself, and Dr. Smitherman. At the end of each disc, there's also a Learn More tab, which lists the multiple community resources that exist in the metropolitan Detroit area with phone numbers and websites. And these community resources are as followed. They're in 8 different categories, including medication assistance, housing services, fitness, free and low-cost clinics, mental health services, family services, and transportation services, and the food pantry. And we're just, in this area, have used this to locate and give people information as to where they can actually obtain their services. So with regard to medication assistance, we have listed the Myers free prescriptions, the Michigan Prescription Drug Discount Card, the Partnership for Prescription Assistance in Michigan, Target Pharmacies, $4 generics, and Walmart's $4 prescription drug plan. Under housing services, we have listed the Homeless Action Network of Detroit, Southwest Housing Solutions, United Community Housing Coalition, and the Detroit Rescue Missions Ministries. Under our fitness, we have the National Kidney Foundation, Northwest Activity Center, Meet Up Group, walking groups, and the Walk Your Heart to Health walking groups. All of these are free services by which the patients can obtain their exercise and fitness. Under free and low-cost clinics, we have Advantage Health Centers Detroit, Mercy Primary Care, Greater Detroit Area Health Council, and the Voices of Detroit Initiative. Under mental health services are listed the Detroit East Community Mental Health, New Center Community Mental Health, and the Northwest Guidance Center. Under family services, we have Health Insurance Marketplace of Michigan, the Detroit Area Agency on Aging, the Institute of Population Health, the Women's, Infant, and Children's Special Supplemental Nutrition Program known as WIC, and United 211. And under transportation support, to assist people in their transportation needs, we have listed the Detroit Department of Transportation, Smart Transit, Response Transportation, East Side Butzel Family Center, and Logisticare. And the seventh category of food pantry, we have Covenant House of Michigan, Gleaners Community Bank, and Southeast Michigan. So all of these are listed under the Learn More section at each disc, on each of the 3 discs, and easily attainable for the patients to actually utilize. Again, pictured here, we see 4 of our really storytelling participants. These are married couples. We see James and Pam, and Keith and Leela. So we have long known, that patients and doctors have understood the power of telling stories and listening to personal narratives. And we know that storytelling effectively counteracts the initial denial that can arise when a patient learns of a new diagnosis or is asked to change their deeply ingrained behaviors. The magic of stories lies in its relatedness, and the patients can actually relate to each other, and this helps foster the change that we desire. So our hypertension intervention project timeline is as follows. I'll just describe it for you. We have about 350 patients who will participate in actually viewing this 3-disc DVD set that we actually created. So the 350 patients are divided up among several sessions that appear and they come to our Wayne State University School of Medicine, where we actually hold these sessions. And at the session, they actually receive a folder with a description and timeline of the program, information about hypertension, and all kinds of educational materials that are in that appear in the folder. There's a sign-in that consists of them signing waivers and participation agreements, and at that first orientation session, they actually get a blood pressure monitor, and we teach them how to use the blood pressure monitor, and they record their first blood pressure reading at this first session. At this first session, we also watch the first video, and as a thank you, they receive a free $10 gift card. Following this first welcome session, then within the next 2 weeks, the patient or the participant will actually take their first survey online or on telephone, depending on which type of information they told us they want to do their surveys by. Over the next 3 months, they'll watch the second video and incorporate what they've learned about managing their blood pressure into their everyday routine. Month 3 of the project, patients take the second survey online or by phone. Over the next 6 months, then they watch the third video or rewatch all 3 and incorporate what they've learned into managing their blood pressure into their everyday life. Month 6 of the project is when the third survey is taken online or by phone, and people are and they actually are summarizing basically what they've learned from all 3 videos. At our closing session, which will be held next year, we'll meet in person again to talk about the highs and lows of the project, take a final blood pressure readings, and take a final survey. And month 9 of the project, after the closing session, they will get a final survey online or by mail or over the phone. And in the packet is a journal where they can actually keep record of their blood pressure screenings, and they are encouraged to talk to their physicians about their blood pressure readings. And we do encourage people, obviously, before they do anything that we've recommended, to definitely check with their physician who's actually sent them to participate in this study. So as you can see from this slide, only about 40% or about half of people with high blood pressure have their condition under control, and reducing one's systolic blood pressure by only 12 to 13 millimeters of mercury could actually reduce stroke by 37%, coronary heart disease by 21%, and deaths from cardiovascular disease by 25%. So the design of both our interventions, which focus on improving the quality of care and reducing hypertension rates in African Americans, that then reduces the rates and increase of cardiac disease, is the major focus of our GDAC Aligning Forces for Quality 4.0 Cost and Quality Goals. Now, our storytelling videos are available through the YouTube link on our GDAC website, and our website is www.gdac.org. And we have an amazing team of people who worked very hard from the start, behind the scenes, in getting and organizing the production of the video, getting physician participants, and so I just didn't want to leave without acknowledging those people, of which are Dara Harris, who was our consumer patient on our team, Parada Jordan from the Voices of Detroit Initiative, Tapri King from MPRO, Quentin Moore from Trinity Health System, Melissa Ottinger from MPRO, Lillian Preston, who actually did the amazing video work, Leslie Welch from the Institute of Population Health, Pamela Williams from Harper Hospital, and we had several interns, Marissa Cooper, Arun, and Yuna, and Nadine. And we couldn't have done any of this without our leader, Tawana Nettles Robinson. So at this time, I'll turn it back over to Susan, and we can proceed from there. Thank you.
Thank you so much, Dr. Gibson-Fountain. It's clearly really wonderful work that you're doing in Detroit, and I think you've just hit on a really important part of this work, which is keeping the patient's voices front and center, always in our planning, our implementation, our evaluation, all along the line. So we have gotten some great on-the-ground information, and we are now moving into the question and answer session. If you'd like to ask a question, please select Q&A, which you can find at the menu bar at the bottom of your screen. Type your question into the pop-up box, and the question will automatically be added to the question queue. But to start us off, I'm just going to ask a question of both of our presenters today. And, I think you probably sparked a lot of interest amongst the listeners. And there very well may be somebody from a community or a regional health collaborative who's listening, and they really want to either start or build upon the work that they're doing in this arena. So if you had to pull out 1 to 2 really critical learnings from your work or words of wisdom, can you please each do that and share it with the audience? Just sort of 1 to 2 highlights of, tip advice or words of wisdom that you would give to somebody wanting to start in this work or wanting to build on work that they're doing.
Sure, I can go first if that's okay. This is Tom Love again. So I'll focus on the reporting end of it and say that the thing that we've learned, or that we wish we'd known when we started, I guess, is that despite our best efforts to involve multiple stakeholders at the beginning, to get as many different points of view as we could in the room, we were confronted with over the years, we've been confronted with numerous cases where we wish we had made slightly different decisions about how we would do things, and that taking this very global viewpoint of looking at disparities across multiple conditions, multiple outcomes of interest, multiple different ways of thinking about disparities, as I mentioned, beyond just race and ethnicity, was the crucial idea. But what was most important was to get the various people who were providing data, who were paying for care, receiving care, providing care, all of those people interested in understanding at a regional level what was happening in a broader sense than we had initially. So all of the things that at the start we thought were important turned out to be important, but there were other things that were even more important that we weren't thinking about at the beginning. So it's getting a group of people together and committing to the process of constantly thinking through how can we do this better, that was the key thing that has let us be successful so far.
Great, that's really helpful. And Dr. Gibson Fountain, I know this is a tough question because there's so many, but
Right. There are so many. Key that jumps out to me are some of the statements that the patients made with some of the reasons that they didn't take their medication. Obviously, we know the obvious ones with regard to the money or the having the funding to actually purchase the medication, but as well, just there were so many different things that came out with regard to patients just feeling comfortable with the physician talking to them, not feeling like they were being experimented on. Dr. Levy, who's on our one of the participants, one of the physician participants, was actually involved in a study here in the Detroit area where we discovered that when you do change a patient's blood pressure, when you decrease their blood pressure, actually because the body is used to the steady state of the old high blood pressure, when you decrease the blood pressure to normal ranges, then people feel sick and ill, and some of the times patients attribute that to actually being due to the medication that they're on as opposed to just the resetting of the steady state of their body to a normal hypertension or normal blood pressure level. And so knowing those things and being able to discuss those things with the patient, but often the patients would bring up how they wanted more information and wanted to know that the physician was listening to them and that they were being heard, and that when they called with questions that they would be able to be answered. And so the thing that came across my mind upon listening to all the patients is that listening to them and knowing that they do have a desire to be healthy and get the information, but oftentimes they feel that we as physicians aren't able to give them what they desire due to the fact that of time constraints and maybe cultural barriers and some other things. And so that's one of the major things. And then the other thing that was glaring is just the universal denial that people, when they were told that they had high blood pressure for several reasons, didn't want to accept it. They'd grown up watching their families take medications and whatnot, and thought that it was either a lack of a showing of strength or just a failure on their part if they were diagnosed with an illness. So there's quite a few glaring things that came out that we couldn't see going forward will be helpful. The literacy part that we're getting into, we're actually developing a talking touch screen software to given physicians and get into physicians and healthcare providers' offices, which will help make sure and ensure that people actually understand the medication regimens that are given to them, and it can be interactive. And so we're working on that point as well.
Thank you both so much. It's really, I think, so helpful when we hear the actual experiences of trying to get this data and trying to implement interventions really from the people who are doing it. But I understand we have many questions that are coming from our audience now, so now I'm going to turn to some of those questions from the audience.
Thank you. Our first question is, what resistance or pushback did you encounter in your journey, and how did you address it?
All right. Well, I can speak to that very briefly. So we've encountered resistance in multiple areas, but I'll stick specifically to the racial disparities issue. The first piece of pushback that we got was that by focusing on race, we were going to miss out on other opportunities to understand differences by insurance or medical records. So obviously that motivated a lot of what I talked about earlier today. So that was one area, this notion that we couldn't just look at race by itself. A second area of pushback came when we when we initially started doing this, we weren't looking for language disparities. We weren't looking at language. in a serious way, essentially because we believed that only a few of the practices involved had significant numbers of patients who preferred not to speak English. That turned out not to be completely true. That is to say, there are some practices that have more patients like that, but there really aren't any practices that are exclusively speaking English with their patients. And so it took a while to get the systems in place to get that reported properly. Systems who have electronic health records, of course, have an easier time reporting that sort of information to us. And the quality of that data has improved over time as we've been reporting it. So we started with about 90% of patients having a well-documented language, and now maybe we're up at 98% or so forth of the patients we have. And it's because there's a target. There's a clear sense that this is a direction. So most of our pushback has been along the lines of either you're not doing enough or you're asking us to do something else and that may be challenging. And the main solution has been to try to push forward and be transparent about why we're doing what we're doing and and try to learn each time and get a little better at requesting data in a useful way every time we do it.
For us, part of a problem we encountered was patient participation. We elicited patients from physicians throughout our city and surrounding area, and as you'll note, going through the DVD, we have a wide cross section of patients, both age range and sex. But we would have 40 to 50 people scheduled for one of the orientation sessions, and then on some days maybe only 2 to 3 people would show up. Right now we're around 200 people into our 350, but that is one of the drawbacks. People would sign up after having a letter sent out to them first, and then receiving a phone call telling them about the project, signing up for the project, and not really showing up. So that's been one of our challenges. Another one of our challenges is, getting there's a lot of resources that are available, and obviously the DVD highlights some of those, but there are a lot more. As we talk to patients, we're learning of other resources that are available, such as, the YMCA provides 1 hour of activity to Medicare patients on a daily basis. There are some of the local areas like Whole Foods who have Wow Wednesdays where the people can come shop for 75% of what the Whole Foods prices are the rest of the week. And so those kinds of things we're learning about, didn't necessarily know ahead of time to include them in our resources. And the other thing I would say moving forward is we do get a lot of going through preliminary data. We are seeing a lot of people wanting to know how they can use the DVDs and get them and, disseminate them into the community through their churches, through their schools. A number of the patients stated that we should really start and involve younger people, because the father and son team, the dads say, well, I wish I would have, known this, and then I would have been better able to teach my son. So, and then the other 2 married couples both said that that we should go into the schools and give this information to school-age children as well as young adults, and not wait till patients get old. So those are just some of the things that we noticed.
The next question is, how did you collect such specific data from participating systems, Tom? What data did systems have to collect from patients, and how did they do it?
So we had 2 kinds of systems. We had systems, now we exclusively have systems with electronic health records, so the gathering of data is somewhat easier than it was previously, and we have a set of data elements related to our individual conditions, so things like what your blood pressure was, for diabetes, hypertension, and heart failure. But then we have a core set of data elements that we gather on everybody, which relates to demographic information and race, ethnicity, and preferred language, and so forth. And those systems with electronic records have, in some cases, modified their systems so that instead of having things show up as free text, that they are available now as checkboxes or drop-down choices. This was particularly an issue for establishing language as something we were going to gather in a substantial way. And many of those systems have undergone some training opportunities, especially for support staff to get that data, get that right, and get that into the systems. So that's been a piece of it. The other systems that participated that used to have paper records, then we did that through chart abstraction. So you can imagine that the quality of that data for some sorts of things was pretty good, and for other things was not as good as they were working from paper charts. So we've seen all of these things improve over time as the systems involved with us, which go from the Cleveland Clinic, which has as much money as any system in the country, down to federally qualified health centers that are scrimping for every dime. All of those systems report the same data to us each time now, which has taken 7 years to get to, but is a real achievement, I think.
Thank you. We've had a number of requests for a repeat of the GDAC website. It is the Greater Detroit Area Health Council. That's GDAHC.org, and that URL will also be shared after this webinar. Cheryl, a question for you. Any estimated costs for participants in your intervention?
So are you asking if the participants had to pay, or how much we had to pay, or how much it cost us to do the program?
I believe the question is if there are any estimated costs you have for running the program.
Yes, so I think our total cost is about $50,000. And we're actually, we received an additional $5,500 just recently from the Beaumont Health System. So I would say $50,000, around $50,000 is the cost, our cost. But now the participants themselves, there was no cost to them participating.
Great. Our next question is general. I would love to hear your perspectives as healthcare leaders about what kind of community support system changes would help reduce disparities in your communities. Who is critical to have around the same table to make headway on these issues?
So in our case, I'll say that the critical people to have at the table are the usual critical people to have at the table for any sort of regional health improvement collaborative. That is to say, it's a combination of multiple stakeholders, including obviously the people who pay for care, which includes both insurers and things like government agencies, and of course providers and patients. But we found that the most important groups of people to have are the people who are committed to specific areas, specific parts of the region geographically, and to get a reasonably wide range of those people. So there are different problems in different parts of Cleveland, and without knowing that, we would have very little ability to make any progress in a given area. So what's been most important to us is to have as expansive a list as possible of people who are focusing on population health and public health problems across the region, which, as I say, largely falls into the same category as what we think about everything, not just disparities.
Right, and I would agree with those that were just mentioned, and in addition to the, obviously the community resources, the patients, our physicians, colleagues, other healthcare providers that provide care. We need additional help with data collection and analysis, and actually dissemination of our project results, and then the implementation of our clinical screening tools into our EMR systems moving forward. So, I would agree that those previously mentioned, but also, in keeping in mind, for us, we need those additional resources.
Great, and we've now ended the Q&A session.
Okay, thank you. Sadly, we don't have time to answer all of the questions, but we do have them recorded. So if we were not able to get to you, and you had a specific question for our guest, we will make note of it and try to follow up directly offline. So with that, it just thanks leaves me to thank our speakers who joined us, Thomas Love from Better Health Greater Cleveland, and Dr. Cheryl Gibson Fountain from the Greater Detroit Area Health Council. And thanks, of course, to all of you on the phone for joining the webinar today to discuss the lessons that we've learned for the really critical work about addressing disparities in care. And we hope that you found this helpful. Disparities in healthcare are clearly important, they're clearly pervasive, and we clearly need to continue to work on them. And so we at Robert Wood Johnson Foundation and programs such as Aligning Forces for Quality remain committed to addressing disparity, and I hope that you will join us in this work. The resources that were discussed today in today's webinar can be found at www.rwjf.org/equity. And in the next few days, we're going to be posting the slide deck and also a recording of the webinar on the site. So if you need to listen in again on anything that you wanted to hear or you want to share this with anyone, please feel free to do so. And we're going to be continuing the conversation that we started today on the RWJF Quality Equality Twitter handle using the hashtag AF4Q. So again, that is the letters AF, the number 4, and the letter Q, all one word. So thank you, everyone, for joining us today, and I wish you all a wonderful rest of your afternoon. Thank you.